All right, so let's talk about this. All right, intro to pathology. A lot of this stuff, unfortunately, the way we have to look at the book, the first 20%, 25% of the book is memorization. I can't help you with that. It's just terminology of what a disease is and what incidence is and so forth. But believe me, if you could just bear with me and understand these terms, we're going to use these terms once we get into all the systems. Okay? So it's just right now, I wouldn't say it's boring, but it's going to be just like terminology, and I'll try and give you some pictures to make it a little bit more fascinating. Okay? So let's do this, and I'm going to breeze through this quite rapidly. Organizations you should definitely know going into the medical field. The World Health Organization. I'm sure all of you have heard about this. The World Health Organization is a combination or a union of 194 countries or regions that are members, and they put everything together about all the different diseases and preventions that are happening throughout the world to make people more alert of what's going on, where there's epidemics in the world. So they kind of do that kind of thing, collects data. One of the biggest things that they're noted for, one of the successes, is the eradication of smallpox that happened in 1980. In other words, the last case of smallpox was in 1980. If you know anything about smallpox for the past 400 years, smallpox has probably killed more people than any other infectious disease. So this is something they're very proud about, and then hopefully we could get a lot more. I would hope that hepatitis B would be the next one that we can eradicate, like in vaccinating people and stuff. But it's going to mean worldwide people have to do that. Okay. So World Health Organization, you'll see that in the news and stuff. The other one that you should all know about is C.D.C, the Centers of Disease and Control and Prevention. Okay. This one is an organization in the United States only. World Health Organization, by the name implication, it's the whole world. This is specifically just the United States. So true. CDC is going to send information to the World Health Organization so they can collect the data and put everything together. But this is specifically for the United States. It's going to promote health and quality with life and trying to see what we could do about preventing certain diseases in the United States. Okay. So that's what this is. And the big thing about the CDC and the World Health Organization, that any article, whether you read it in a newspaper or in the New England Journal of Medicine, whatever they say is what's going to hold water. I don't care what the president says. I don't care what your teacher says. All right, these are just thoughts. I don't know where they got the information from, okay? But if the World Health Organization or the CDC says that there's an epidemic, there's an epidemic. If they're saying this is the best way to prevent it, this is the best way. This is the one in newspapers that will hold water. So keep alert of these two big organizations. These are going to be big throughout the whole rest of your careers. Okay? All right, so the disease process. Disease. Basically, we got to protect our bodies. Okay? So when a disease occurs in our body, it's either going to adapt to that disease by fighting it or whichever, or you're going to die. So how are you going to protect it? Well, there's three mechanisms to protect it. Okay? And if you saw me with the chapter 2 thing, basically what's going to happen is you have three mechanisms. The first one is this normal body structure. Your skin, the tears in your eyes, the earwax in your ears. This is the first line of defense. Okay? That's what's going to block things. If something could get through your skin, then we have a second line of defense, and that's what inflammation is all about. Inflammation, it's going to inflame the area, and chapter 2 tells you all about where that happens. If it goes further and the inflammation process is not going to work, then there's going to be something more stronger, or more strong, and we have antibodies and cell-mediated areas. So what I kind of use, and I use this for chapter 2, is that if you're trying to protect your house, you have the first line of defense is your picket fence. That tells everybody, whether it's Aunt Tilly or a mailman or a burglar, that that's a private house. You want to get through there, you're going through private property. That's my skin. Okay? You break through that, we have another line of defense. Fido. The guard dog. Right? What happens here in the picket fence that's going to block good and bad people? Fido, with him barking, that's going to fight off good and bad people. He will bark whether it's Antilles or a burglar. It's non-specific until the master comes out of the house and says, Fido, what are you barking at? What's going on here? He's more specific. He's going to say, Fido, that's a burglar. Continue to gnawing off his leg. I'm going to go call up the T cells and B cells to get over here. See, it's more specific. Or the master comes out and says, Fido, that's Antilles. Just lick her leg. It's okay. Right? That's what I'm saying. It's more specific. It could tell between friend or foe. This is the line of defense that we have. Okay? Immunology. Questions on that? Okay. Okay, so here's some basic terminology we got to do. Just a long list of just words. Okay? First off, if you're going to be a nurse, you got to learn the abbreviation stuff that I put on here, that a lot of doctors' notes and nursing notes are going to put on here. You just have to get used to seeing these things. Patient is PT. You're going to have antibiotics, which is ABX. You have medication RX, TX is treatment, and so forth. So try and get in a habit of using these. On exams, I won't use these abbreviations, but for your own notes, because you're going to be writing a lot of notes and stuff, get in a habit of doing it. Okay? On my PowerPoint, you'll see it on there. So let's start off with a definition of what this course is all about. Pathophysiology, study of underlying changes in our body's physiology that result from the disturbances of your homeostasis. Disease comes in, your body's going to change. Okay? When I say come in, I mean it's not just an infection that comes in. You can get diabetes. Your sugar's going to go up and up and up. How is your body going to adjust to that? So it's the mechanism of disease, how things are all being put together here. How and why your alterations occur during the exam or during the disease. Why are you getting certain signs and symptoms? You've got to understand the mechanism, right? Like I did the thing earlier for you in terms of like increasing aldosterone. Understand why you would get, let's say if it's an increase of aldosterone, why would you get hypernatremia and hyponatremia and low blood pressure? Don't memorize it, understand the concept. Okay? The pathogenesis is just that. The pathogenesis is the stages. You have this new disease, then this leads to this, leads to this, leads to this. Right? It's a staging of what's going on here. Okay? The development of the disease. We have pathology. Pathology can be broken down into two things. Anatomical pathology, which is the structural alterations that occur. We call them lesions. A lesion in the spinal cord, a lesion in the adrenal gland. Something that's changing that's structurally. And the way we could see this is either grossly, and I don't mean gross like you, gross meaning like what you can see with the naked eye, okay, like gross anatomy, or microscopic. So you're going to have to take biopsies to see what's going on, to see what's happening with the cells. We also have clinical pathology, and that's really dealing with the laboratory aspect, all right, of the body fluids. What's happening with urine, what's happening with the cerebral spinal fluid and the blood and whatnot, okay? Disease versus illness. He's ill. He's got a disease. They mean the same thing. Not really. I mean, they do. They don't mean the same thing. They correlate with the same thing. So disease is a pathological condition the body is going through and changing the normal body, okay? They're using things that you can see, things that you can measure, all right? Disease is more of a, you could see what's happening to the pancreas causing the disease of diabetes. It's more objective, it's more concrete. And illness is more subjective, all right? What what the patient is actually experiencing. I'm feeling pain. I'm feeling lousy. You can't really measure that. And that's what an illness is. It's how they perceive themselves. It's highly individualized. So therefore, treatment between the two terms is difficult. It's easier to treat a disease than there is to treat an illness. I can treat the brain tumor. I can't really treat the headache. That headache could get worse and worse. Or the patient's telling me it's worse and worse. But I can make the tumor getting smaller and smaller. You know what I'm saying? There's a difference. So we have diagnoses. How do you diagnose something? So you're basically distinguishing one disease from another. And we use different things to help us diagnose. Signs and symptoms. And there's a difference between the two. We'll get into that in a moment. Medical history. Getting an understanding. Talking to the patient. Asking them, all right, you had this abdominal pain. Where is it? When do you get it? When does it get relieved? Does it get relieved with medication? Does it get worse? Is it is it better when you walk? All these different things is going to help you. How long have you had it? How long does it stay? All those questions are going to help you to figure out, is this because of your stomach? Is it because of a mole there? Is it because of musculoskeletal? Those questions help out, okay? The physical exam. After you get the history from the person, and also getting, does anyone in your family have stomach cancer? Are you taking any medications? Do you smoke? Do you drink alcohol? All those things will help you with the medical history. But then you got to sit back and you have to now do a physical exam on someone. And a physical exam means that you're going to do a non-invasive way to examine that patient. You'll do inspection by just observing. Is there a big mass over there? Is the person red? All these kinds of things by just looking. You'll palpate. You palpate the stomach and realize, or the abdomen, and realize it's pretty tense. Or maybe it's, you can really press down and there's not much pain there. Percussion. That might be a new word for you. Well, percussion is I don't know if you've done this before, where you tap on certain things. All right, you put your finger over here. You won't have to do this now, but you tap on here. And there's ways that you can actually tap on certain things and realize, is it a solid, or is it gassy, or is it a liquid in there? And there's different ways you could do that. You'll learn that later on, but we do those kinds of things. And then also auscultation. Just listening to, with a stethoscope, listening to the abdomen and see if you hear fluid going through there, or if you hear your bowel movements, not movements, but you're hearing things go through, or listen to the heart. So these things are non-invasive, and believe it or not, if you do a very good medical history, you do a very good physical exam, 80% of the diagnoses will be because of that. All right? 80% comes from medical history and from the physical exam. The other 20% is going to come from laboratory tests or CT scans and whatnot. It's being able to ask those questions. How are you going to do that? Well, you need to know about signs and symptoms and all the stuff that we're going to go through with all these things for the rest of the semester. A differential diagnosis is basically through your H&P, your history and examination, or a physical examination, what's your best guesses at what this person has? He comes in complaining of epigastric pain, all right, or pain in the abdomen. By doing the history, are you thinking more musculoskeletal reasons? Are you thinking more GI reasons? Are you thinking he has pneumonia? Think of how low. If he has pain over here, why can't it be your lungs on one side over here? You can't decipher where it is, where the diaphragm is. It could be referred pain. You could have pneumonia up here, and it's pain over here. Sure. So you have to try and guess what's going on. Maybe he doesn't have a fever, so you're not thinking pneumonia. Maybe he does have a fever. If he has a fever, we could probably throw out the idea he has peptic ulcer disease. So you've got to be able to come up with your what we call a differential diagnosis. What's your guesses, your best educated guesses? What are your 3 guesses of what this person has? Right? You don't want to say, well, they got this, and come up with 20 things. It's like, go back to nursing school. Go back to medical school. You can't come up with 20 different things. What are the 3 possibilities? Right? Okay? Sign versus symptom. A sign is something you can measure. They're objective things. You either can see something physically or you can measure it. Things like a fever. I can measure that with a thermometer, right? I could see a swelling there. Just look at the two knees. One looks more swelled. You can see that. A rash. Nope. You figure out that part, right? High blood pressure. You can measure that. These are all concrete things. These are all objective things. Symptoms are subjective. Patient has a headache. I can't measure that. He tells me he's got a headache. He feels nauseous. I can't measure that. He sees things. He has hallucinations. I can't measure that. You see? So there's a difference between a sign and a symptom. Signs are objective. Symptoms are subjective. Okay? So tenderness is when I press down on so someone comes to me complaining that they have pain. That's a symptom. That's what, I can't elicit that. But when I press on an area and let go, or press over here and says he has pain, that I can measure. You see? There's a difference. That's tenderness. Is he tender over there? Tenderness is a sign. Pain is a symptom. Okay? So nausea, I feel nauseous. That's subjective. I'm vomiting. Well, I can see that. See, vomiting is a sign. Nausea is a symptom. Okay? Does that make sense? Pretty straightforward. Prodromal period. This is the period of a disease where you have vague symptoms prior to the full-blown disease. I have pancreatic cancer. I'm just feeling, I feel feverish, I feel lazy, I get tired. Vague kind of symptoms where it could be anything. But not that you're vomiting up green vomit, that you're not, you're creating, those are more the classic kind of things that you'll see with pancreatic cancer. So the prodromal period is what we call, we have these vague kind of symptoms, it could be just anything, right? The latent period is when you actually have the disease, but there's no symptoms. We call that subclinical. You have strep throat, you have the streptococcus in your throat, but you don't have any of the symptoms of it. Maybe 2 days later you'll get it. So if you don't have the symptoms, we say it's subclinical, but you still have it. Does that make sense? Right? Breast cancer. You could have breast cancer, but there's no symptoms that you have. That's where we have problems, because the symptoms might not appear until stage 2. Okay? Syndrome versus disease. A syndrome is a set of signs and symptoms that tend to occur together and which reflect the presence of a particular disease or developing particular disease. Difficult with symptoms, or I'm sorry, with a syndrome, because we don't have a reason. Well, it's caused. The symptom is caused by a syndrome, but does not have an established reason. So, in other words, the cause of the disease is there. A good example is Down syndrome. Okay, we know what causes, or the cause of Down syndrome is something we call trisomy, which is an extra chromosome, chromosome 21. But we don't know why you get all these other things with it. That you have a decreased mental capacity, that you have epicampal folds over here, that there's something wrong with your eyes, that you have the simian line over here, you have a crooked pink. Why we're getting all these different things, we don't know, but we know the cause, not the cause, but we know what's causing the Down syndrome. Okay? Does that make sense? All right? So, so we have this medical mystery. The cause of most syndromes has not been identified, meaning we don't know what's caused that trisomy 21, but we know it is trisomy 21. Does that make sense? What caused it, we're not too sure. We know that there's risk factors. You want to be pregnant at 50 years old. Yeah, you have a higher risk of having Down syndrome for that to happen. It's called non-disjunction, what's happening, but we don't know why it's happening, right? So some diseases can cause a specific syndrome, all right? And that's why I said Down syndrome is a good example. So in other words, we know what and how has happened, but we don't know why it has happened. Okay? So to give you an example, this is a normal karyotype of a normal person. Okay? So you have two pairs of chromosomes for chromosome 21 over here, or not one pair. So you're going to have one from dad and one from mom, right? So you have two over here. Okay? There's the Y, so you know this is a male. What happens in Down syndrome is that you get 3 copies of chromosome 21. The reason why this happens, if you go back to meiosis, is that we have 2 divisions in meiosis. It's called non-disjunction, what's going to happen here. The first one divides properly, but the second one, this one divides properly, but this one does not. So you got an extra pair here. So if this is a sperm, and it goes with an egg that has one of these, now you got 1, 2, 3 trisomy. And if it happens with chromosome number 21, we say trisomy 21. You could have non-disjunction happening at the first division in meiosis, and that leads with 2 over here. See? So we know what's happening. We don't know why there's non-disjunction. We know that women who are over 35 years old, there's a greater risk that this is what's going to happen. And that's why we see women over 35 having a lot more Down syndrome babies. Okay? Not saying that, you know, you're 41 years old, I don't want to scare people and say, oh my God, I don't want to get pregnant again. Because actually, and this is just off to the side, there's more people under 35 years old having Down syndrome babies than people over 35. That's because most women have children under 35, so there's a greater percentage. Okay? And there's a little kid, right? And these are other things. So we know that Down syndrome has a decrease in mental capacity. But there's other non-things, there's other non-mental features. You have this simian line that happens in the palm. You also get these epicanthal folds over here. And if you see these little dots that go in your iris, those are called Brushfield spots. You don't have to have all these different things. There's also a pinky that's crooked. This is why I'm saying the internet can be really bad. I have a crooked pinky, but I don't have Down syndrome. You see, you got to have, like I said, if there's 15 features of Down syndrome, you got to have like 9 of the 15. Does that make sense? So the internet can be very bad. All right. So just showing you those. There's a syndrome of different signs and symptoms that would be that. All right. So chronic fatigue syndrome, the cause has never been established, but the symptoms are usually tackled by medication. All right. So that's what's going on with that. All right. Some exceptions. Well, here's one exception. It's acquired immune deficiency syndrome. Now, this is one that we know exactly what actually causes this. The HIV virus, right? Or the HIV, right? So we know what causes that. It's an infection. But the problem is, in the early 1980s, we didn't know what the cause was. This is when it all happened. We didn't know what the cause was. So the problem is with this, the name AIDS kind of stuck. And we still call it a syndrome over all these decades that has gone through. So that's kind of like an exception of what a syndrome is in that case. We know the cause of it, but we still call it that because it's just, the name just stuck. Okay? Epidemics. This is the one that drives a lot of students and doctors nuts. Epidemics are really diseases or procedures or an operation or structure or maneuver that's named after someone who discovered it, all right, or invented it, or the person that died from it. They have no, it doesn't tell you anything about the disease. Okay? For instance, you have Down syndrome. It's named after the person who discovered it. Lou Gehrig's disease. Here's the person that died from it. All right? I would rather be named after it because I discovered it, not died from it. Right? Well, Lou Gehrig's disease is the so-called ALS, right? The ice bucket thing, right? Or really called amyotrophic lateral sclerosis. So these Papa Nicolau, right? That's our pap smear. We cut it down to pap smear, but that's what it is. It's named after the physicist that actually invented it, the procedure, back in the 1950s. So we just call it now the pap smear. But they're named after something. So that's why I said this is a little bit rougher, because you just have to memorize that. If I said pancreatic cancer, you know it's cancer of the pancreas. If I said, Alzheimer's disease, you don't know what that is. It doesn't tell you anything about what that disease is. That's why eponyms are a little bit nerve-wracking. You just have to memorize those. Prevalence versus incidence. Prevalence is the proportion of a population who have or had a specific disease. So we could say, what is the prevalence of obesity during 2007 and 2017? How many people in the United States were obese during that time? Okay? Or what's the prevalence of smokers just in 2017? Right? It's the number of people that have it, as opposed to incidence. We're talking about new cases. So I could say, what's the incidence of brain cancer in 2017? I don't want to know all the people that have it. I want to know how many people were newly diagnosed with it in 2017, right? So there's a difference between prevalence and incidence. These words are all going to pop up throughout the rest of the course and the rest of your careers. Morbidity and mortality. Morbidity is basically the number of people with an illness or a complication of an illness. And we usually refer to it as a morbidity rate. Okay? Mortality is basically the number of people dying from a specific disease. Okay? And we refer to that with like a high mortality rate, a low mortality rate, right? People dying or not dying from that disease. Other terms, these are just ones I found this a little bit easier for me instead of typing it, but you should know each one of these things. Like prognosis is information regarding the likely outcome of the disease. Is it a good prognosis or a bad prognosis? I mean, cancer is always bad, but there's some that are a better prognosis than others. You could last longer than 5 years and stuff. So that's what these terms. Predisposing factors, okay? Basically, a condition or situation that make a person more at risk of a disease. And these are the things that we need to do. These are kinds of questions that we ask in a medical history to help diagnose what that person has. So we could have heredity. Does anybody else in your family have that disease? To see if that trait actually is passed down. Whether you have it, well, because if my father and my sister have diabetes, there's a strong prevalence that, or a strong possibility that I might get it. Because it's in my family, right? I could just thank mom and dad for giving me those wonderful genes. Okay? So it may not appear at birth, but 10 years later. Okay? I carry a gene for diabetes. I might not get it at 10 years old, or even at birth. I might get it at 50. Okay? So if you know heredity risks, then it's going to hopefully change the way you do things. If I know that I'm a risk for getting diabetes, then I should change the way I eat my foods and maybe do more exercise. Maybe it's programmed in my body I should get diabetes at 40 years old. But if I do other precautions, maybe I won't get diabetes at all, or maybe I'll get it, let's say, 60 years old. I bought myself 20 years. So knowing these risk factors help you. Okay? age, right? Certain things like Alzheimer's disease happens more. So you're thinking if someone's got, let's say, a forgetfulness at age, let's say, 60 years old, that could be Alzheimer's disease. But someone's forgetful at 6 years old, not, right? So that helps out too. Otitis media, an ear infection, more often in children because of the way that the eustachian tube is positioned compared to an adult. Okay? Elderly has more unique problems because they can't tolerate temperatures, extreme temperatures as much as a young person can. They do less physical activity and so forth. Okay? Gender. There's just certain things you just can't go without, right? Ovarian cancer, obviously men don't get that. But women don't get prostate cancer, right? Let's say breast cancer. 1 or 2% of males do get breast cancer, but it's more prevalent with the women population, right? But lung cancer, it's equal. Heart disease, it's equal. Okay? So knowing that when you present that patient to someone else, if you're going to talk to another doctor or another nurse or whatever, it's good to say, here is a 40-year-old female, here's a 40-year-old male. That information is helpful to help diagnose. Environment and occupation, right? This kind of, if you're a typist or piano player, you're going to have an increased risk of carpal tunnel syndrome, right? If you're living near deer-infected areas, then there's a good chance you have Lyme disease. So that's helpful. You're getting, let's say, certain rashes, you're feeling very tired. It's good to tell the doctor or the nurse that, hey, look, I just went camping the other day. That helps out. If you didn't go camping at all, if you live in the city, why would you be getting Lyme disease? It doesn't make sense. But if you've been camping lately, this will help with the diagnosis. Lifestyle choices, right? Street drugs, right? Smoking, lack of exercise, that'll also help with diagnosing.